Thank you, Razia, for presenting this wonderful case. 67-year-old female with lateral ankle pain. And we can see that we have, if we look at the axial images and we take a look at the peroneus brevis and the peroneus longus and the tenosynovitis, as we come down, we can still see tenosynovitis, longus tendinosus, the superior peroneal retinaculum. This is an accessory peroneus cordis. Superior peroneal retinaculum with periligamentous edema. The band is intact. There's no subluxation. The brevis in its inframalleolar location, peroneus longus, and the peroneal tubercle indeed is hypertrophied, has stress response, and is the decussation between where the brevis will go to the base of the fifth and the longus will go through the cuboid tunnel and then get to the base of the first metatarsal. So indeed, we have this hypertrophied peroneal tubercle, and let's just take our way through the case. So we can just start with axial imaging, looking at the hypertrophic PT tendinosus and mild tenosynovitis, flexa dig, flexa hallucis longus. They're going to come to the master knot of Henry and Cross. We have some mild medial flexor tenosynovitis, and it all attaches on the medial navicula. We like to see the rest of it on the coronal images, looking at the posterior tibial tendon coming down as it attaches 50% on the medial navicula, and the remaining going to these struts that are going to go support the metatarsal and cuneiform bases seen here. Medial flexor tendons, getting back to the lateral flexor tendons, again, the superior peroneal retinaculum, the periligamentous edema, the hypertrophy tubercle with stress response. And now let's take a better look through the cuboid tunnel. Let's take a look at that on our sagittal imaging, and we can see our peroneus longus as it comes through the cuboid tunnel. Notice that the caliber in this location is thinner, and that's something I will call type 2 tendinosis. And of course, we can get all the way through our anterior tunnel. Let's take a look at ligaments. Syndesmosis, intact. Interosseous ligament, intact. Getting down to the ATFL, we can see that there's sprain, thickening, periligamentous edema. The PTFL, poorly defined, minimal synovitis. And the calcaneofibular ligament, we can see with periligamentous edema. Let's take a look at that coronally as well. So we have a double-banded ATFL, and we can see that this is a thickened, wavy ligament. So that's a subacute on chronic sprain. The calcaneofibular ligament we're going to see is that hammock that's going between the tip of the fibula, and we can see that at the location of the fibula, there's some edema and mild inflammation of the calcaneofibular ligament. It's minimally thickened, and of course, we can see the PTFL back here. If we really want to identify what's going on with these ligaments, it's imperative that we use our T1 images too, so that we can see the thickening and the obliteration of the fat recesses that exist in these locations. So all in all, we have subacute on chronic lateral collateral ligament complex sprains. Moving on to the deltoid, you can even see here that the deltoid has like a darker appearance and has more fat. So this might be on the order of something that's slightly more chronic. So when we look at the difference between a ligament that looks like that and like that, there's subtle differences in how much edema and synovitis is occurring inside of this PTFL versus the deep deltoid. Nonetheless, the deep deltoid is thickened. There are some cystic degenerative changes at the tip of the medial malleolus that tell us that it's continuing to sprain. We'll take a look now at our tibial spring and the portions of our superficial deltoid, and we can see that tibial spring as it dives down into the region of the supromedial band of spring ligament. This is thickened here. We can see some synovitis, and of course we have our medial bands and our plantar bands again. Looking at those on T1 weighted image, we can appreciate the superficial deltoid, tibial spring. We see the thickening of the spring ligament, and we see synovitis in the region of the medial plantar bands. And what we're looking at there is really what's holding the talar head. So these tibial spring to the spring ligament, the medial band and then the inferior band serve to support the plantar medial arch. And we can already see that the talar head is no longer round. It has some facets to it, and that indicates that there might be an overpronating biomechanic and, of course, spraining the spring ligament band that you can see here. Let's take a look at the plantar fascia. I like to start out sagittally just to understand, and this is an interesting shape. We usually don't have this concavity. We usually have either a straight plantar fascia. It's usually not concave this way. So looking at the cords, we see some periaponeurotic edema. And I would say that this is evidence that there's some mild stretching of the plantar fascia, and chronic plantar fasciitis is what you see. Let's take a look at these muscles now. Let's take a look at them on T1 weighted image and understand there are some fatty streaks inside of these muscles, the quadratus plantae and abductor digiti minimi. And if we want to further evaluate the muscles of the forefoot and midfoot, we can take a look on our sagittal images and start to get a sense of how many fatty streaks we're seeing, so that when we want to get better at calling neuropathy, we'll be looking at these things much more quickly. So the practice is constantly evolving and taking a look at what you think these muscles are looking like. What I see here is that the plantar fascial muscles have some degree of atrophy. There's also some mild atrophy along the lateral plantar musculature. And I think it's not at the diagnostic state to call neuropathy at this point, but I'm thinking about it and I'm keeping that in the back of my mind that may be adding to the biomechanical problems here. So I would always urge the clinician to check for neuropathy, especially with foot and ankle disease in the older age category, very common. So it helps to put it into a framework where we can start to understand how to treat and impact this patient. Let's get back to the bony structures. We can see that we have medial osteochondral chronic talar dome injury. There's some subchondral cystic degenerative change. The overlying bone is intact. The overlying cartilage is thinned. And we can see that we have that chronic medial change. Now let's take a look. We have some cystic change on the inner aspect of the distal fibula. Sometimes this has been implicated when I have synovitis and impingement. I'll be looking for cystic changes on the inner aspect of the distal fibula to help me fortify my diagnosis of posterolateral ankle impingement. And what I see here altogether, looking at the talonavicular osteoarthritis and the mid-subtalar joint having degenerative change, I want to take a closer look at that and see, am I seeing an extra-articular anteromedial talocalcaneal coalition here? So I have this rounded appearance for my posterior subtalar joint, and as I get towards the medial side, we can even see ganglia coming through this location. And this is the equivalent of this sort of configuration here between these facets is equal to an extra-articular anteromedial talocalcaneal coalition. And we'll discuss more of that in class and in the tutorials. In addition, we can see there is some middle subtalar degenerative change and dorsal talonavicular enthesopathy and even midfoot degenerative changes. And we could appreciate these changes better on the coronal images. So looking in this location, we have this middle and lateral cuneiform cystic change. Actually, that's the cuboid and lateral cuneiform cystic change. And if we look at that on axial images, we can appreciate that there's some degree of midfoot arthrosis and cystic change. So this patient may be developing neuropathic midfoot osteoarthropathy and cystic changes in that location. Great case. Thank you for presenting it, and I hope that has been helpful. One of the thoughts I have for this peroneal tubercle is that as the compensation of the biomechanics gets worse and worse, we begin to place more pressure on our peroneal tendons because they have to pass multiple joints and multiple pulleys. And so there can be a large amount of pressure, particularly when I want to collapse my arch. I'll be trying to swing my calcaneus into a valgus position if I can. And because of the degree of locking that's going on at the extra-articular anteromedial coalition, it may not be possible. So the way the body is dealing with it is trying to place more stress perhaps on this location. So I'm thinking that the etiology of the stressors on this side is an inability to unlock our joints and truly become valgus in that way. So it's really just forces between the soft tissue structures and the bony structures creating a stress response. And we can even see that when you look at the vector of this, that there's a slight upward slant of the sustentacular talar shelf, something that's been described in extra-articular anteromedial talocalcaneal coalitions. So putting it all together, what I think we have here is an early neuropathy pattern with a person who's having uncompensated biomechanics trying to create a greater pronation. And instead, what they're doing is hypertrophying the peroneal tubercle, stress response, creating stressors on the peroneus brevis and longus, edema all in this region, and even subfibular type impingement will start to begin in this location where we see obliteration of all of these spaces because of the synovitis that's occurring at this lateral ankle. Thank you.